You may recognize my guest today from Oprah Winfrey or from his own show, The Dr. Oz Show. He's got an MD, you got an MBA, you are trained in cardiothoracic surgery, but you are here to talk to us as administrator of the Medicaid and Medicare services. Dr. Oz, thanks for doing it.
God bless.
Dr. Oz, thanks for doing it.
Bless you for having me on. And folks get intimidated by Medicare and Medicaid. Succinctly stated, we have social health care insurance in America for old people and folks who don't have much money, and kids, of course. And, you know, there's other opportunities that have opened up. All that's in was one big agency called CMS. Some folks have not heard of it, but it happens to have twice the budget of the Defense Department. So it's where we, as a nation, put a lot of resources, which is why we ought to do it right.
Let me do Government 101, because you started it right there. For you or me, we talk about these programs, but for somebody who lives in rural Kansas, they may not be familiar with the terms, Medicare and Medicaid. They've heard them all their lives. Well, what are each, and what's the difference between the two?
So they were both created the same day in 1965, so they're 60 years of age. They are the social safety net of the country for health care. Medicare takes care of people who have worked their whole life, generally, and have retired. And as they get older, they often have health problems. It gets more expensive, and they don't have resources to deal with that. So anyone over the age of 65 has Medicare. And there's some other categories, but simply stated, Medicaid is to aid people who are down in their luck, haven't been able to put away some resources, financial resources. And for that reason, and when they get ill, they still have to get health care, so someone's got to help out. So Medicaid is our national effort to help them. That's the population that I think Hubert Humphrey describes so beautifully in a placard that adorns the wall as you walk into our building, the Hubert Humphrey building, which is right across from the Capitol. And he wrote that it's the moral test of an obligation of government to take care of those at the dawn of life, so the children, those at the twilight of life, twilight, of course, being the older folks, and those who are living in the shadows. That haunting metaphor is important because when people are in the shadows, substance use disorder, mental health issues, just down in their luck, whatever it might be, they need help as well. And all great people take care of their most vulnerable. We're a great nation. We're going to do that. But if you tease apart those groups, you realize that Medicaid is the foundation of health care for a lot of people. For example, most kids in America are born into Medicaid. Most kids, 53%, are born into poverty, so they're in Medicaid, or they're on CHIP, which is the children's health insurance. So if you want to get kids healthy, you need Medicaid to work for them. And these are programs that we use now to pay the bills. I would argue, and the president strongly feels, that we can incentivize wiser use of the money if we're thoughtful in how we allocate resources.
Let's drill down a little deeper on that, because if you live in the big city and you make big money, there's a certain approach to health care. But if you are from the small town and maybe you're economically challenged, it's like you've got a double whammy. You may not have the resources to take care of health care, but you may not have health care anywhere near you either. I referenced Kansas earlier. My wife's from Nebraska. You look at these small towns, and I think, how far do you have to go to find a hospital that has certain services? What's the government's role in taking care of those rural areas?
Let me put some numbers on rural areas since you bring it up. Your wife could have probably lectured you on it this morning, but the life expectancy of rural America is 3 years shorter than urban America. 20% higher incidence of chronic illness, almost 50% higher suicide rate, maternal mortality rates are much higher. Part of it is access to care just isn't there. There are no hospitals. When there is a hospital, it's got census of one. And people don't trust that institution sometimes and drive by it. So all of this sort of adds up to the foundation that your zip code is your destiny when it comes to healthcare. And that's unfortunate. We should deal with that. The ability of large urban centers, because they're close to the leadership of the state, they're connected, they've got lobbyists, they're just better able at playing the game. They tend to suck up disproportionate amount of resources that we try to put into the healthcare system, leaving the rural centers behind. That's going to change. And that's actually one of the reasons I came to visit today is the president and Congress, when they passed the One Big Beautiful Bill, which we should talk about because it did a lot of things that I think will save Medicaid, save this program for the vulnerable. It also said, listen, rural health care has fallen so far behind. We can't just put a Band-Aid on a hemorrhaging artery. We actually have to massively reinvest in the system, allow it to transform into a program that actually is sustainable. So we're going to put $50 billion more into rural health care over the next 5 years. That's $10 billion a year and is a 50% increase over what rural America gets from Medicaid right now. 50% more money, not to pay the bills, but to transform the system.
Within that, and I'm reading, I want to make sure I get the name right because I'll mess it up. It's 4 words. Rural Health Transformation Program. Yeah. Within that and the $50 billion, are there particular goals or strategies? What are the goals? Because one of the things I've actually heard you say this is, look, we don't want to just throw money at the program, but $50 billion is a lot of money. So specifically, what are we trying to achieve and who is eligible for that $10 billion a year?
Everybody living in rural America is eligible. This is a space race. We want governors who will get the money from us as we distribute it. So it'll all be done this year, by the way. So by January, states have money to start spending for these programs. You want the best ideas out there. So I want governors working with the smartest people in their cabinet and outsiders, hospital systems, et cetera, getting ideas together, talking to other governors. And we made the argument, and the president strongly believes, because he's an executive as well, is no one knows their state better than the governor. So put the money in their hands, but make sure that you allocate the money in ways that we can actually follow. So think about it this way. You're in a diner. When you walk in there, you don't usually order, from 50 different menus. You have a couple different items that's usually in boxes up with you have the scrambled egg option, you've got the pancake option. So we did the same thing. We created a bit of a menu. The first menu item is workforce development. You need people that can take care of people. There are not enough nurses or doctors in rural America. So if you're a governor, you might say, I'm going to train more nurses. I'm going to empower my community hospitals, my community colleges to do that, and we're going to spend the money to accomplish that goal. That would be an example. Or I'm going to allow credentialed people to function at the height of their licensure. So a pharmacist. There are 85,000 pharmacies in America. So even though you don't have that many hospitals, you got a lot of pharmacies. So if a mom has a kid with a sore throat, it's 10 o'clock at night, what do? Do I drive across state to get an emergency room visit? Or do I go to my pharmacist who's got a strep test, can tell me I've got a strep throat problem, give me the penicillin because it's right there with the doctor supervising, and then I get to go to bed and go to work the next day. My kid gets better faster, and they go to school in 2 days. That's what we want the system to be able to do. So that's an example of how we might transform just the manpower problem.
So better access and more efficient.
At the same time. And that doesn't cost a lot more money. I'm giving people who have training. I mean, a pharmacist goes to pharmacy school, not to dispense pills, but to actually take care of people and give advice. Separate from that, we've got the opportunity of getting hospitals to work together differently. So think about this. If I have a constrained number of resources, because after 5 years, we're not going to be pouring in that kind of money. So let's fix the system. What if I got big hospitals in big cities to adopt hospitals in rural America? And so they start to collaborate in ways that historically haven't happened. So if you're a cancer patient, you can get cancer at your care at your local hospital with the other hospital supervising it. So you know you're getting top-tier care. You're not risking your life. But we've now created a financial incentive for them to collaborate. The cultural connection is as important as the financial one. If the OB team at the big hospital that does 15 deliveries a day is helping the individual practitioner OB who does 2 deliveries a week, in ways that you normally can't even define, understand the complexity of how delivering babies have changed, that makes the care better across the gamut.
How far and wide is the issue? I grew up in Bangor, Maine, which, if you're in the state of Maine, is the big city. But the truth is, it's a really small city. It's 35,000 people. So how many Bangor, Maines are there? When I was a kid, the hospital was kind of the center for all of northern and eastern Maine, had a great reputation. Things have changed, and they really struggle now, both in quality and in their ability to deliver to people all over Maine. I've got to think that's everywhere, whether you go to Idaho or you go to Kansas or you go to Maine.
It is true everywhere. And since I know Maine, my youngest child was born at Maine Medical, which is a massive and high-quality center in Portland. Maine Medical could help the hospitals in Bangor, but also in the northern part of the state, further up, where they truly might have a census of 2 patients. So how do you give confidence to people who are 3 hours away from a great hospital that the hospital that's close to them is also a great hospital. Have them partner, have them collaborate. Let me go one step beyond just the cultural connection. We don't use digital medicine. Transformation of digital care has to happen. It might as well happen in rural America first, and then bring it in to the rest of the country. That's one of the beauties of this program. Whatever we learn in rural America, we can apply to the rest of the country. So if I'm a vet, I've got PTSD, post-traumatic stress disorder, I'm suicidal, and I'm an hour and a half from a big psychiatric center, and there's no psychiatrist near me. What am I going to do? Well, agentic AI, an avatar that understands me, connects with me, that I've actually helped design by my own belief systems, could talk to me about a lot of the things I'm struggling with all day long and provide that information to a trained psychiatrist or psychologist who doesn't live near you, but they could connect with you with telemedicine. It would allow the psychiatrist to be scaled because they don't have enough psychiatrists, period. But so they can take care of a lot more patients because a lot of the intake, that hour discussion that you need to have before you understand the problems could be supported with technology, like we do with everything else we do in the world these days. And those advances might as well be used in rural America. We just never had the financial wherewithal to support those advances. So these medical centers have lagged behind. They don't have the kinds of electronic medical record systems. They don't have record keeping for quickly helping you realize you're making a mistake in your care. This is part of a bigger vision we have. The tech transformation of America has to happen, period, because we can't keep up otherwise. And if it's happened in digital streaming, right? The videos you watch are predicted by what you watched yesterday. They give you advice, right? You order your food. There's many systems now where you don't have to even pick your food. They'll order the food they know you want because we know based on your last year of ordering food what you're going to eat. Banking has been massively changed, including our reduction of fraud, waste, and abuse. All these things have transformed life in America. The laggard is healthcare.
Right, right. Health and Human Services laying off 20,000 people this year. 300 of those fall under your bailiwick at CMS. The worry that some people have is, will healthcare suffer as a result of that?
We are rehiring already. The purpose of a reorganization is to pull back in areas where you had a lot of folks working that you didn't want to have resources dedicated to, doing things that don't make sense anymore in 2025. At the same time, CMS, because it's such a technologically dense entity, we have people who have incredible domain expertise. They're actuarials who calculate insurance rates. We didn't change those jobs, but we knew we needed to reinvest people into the tech transfer, the tech modernization of American medicine. So, as an example, we have 13 engineers at CMS. That's it. 13. 13 people who are engineers, and yet we're going to completely revamp the technology that underpins American healthcare. These software systems at CMS were designed 50 years ago. They're based on COBOL, which if folks are knowledgeable, these are, ancient. It's hard to find people who know.
I studied that in college a million years ago.
Exactly. So when you begin to realize the places we need to reinvest resources, pull them out of the DEI programs, reinvest them in engineers who can build me technology to do the things that a modern healthcare system ought to be able to do. And we want to be the best payer out there. To do that, we have to re-envision what that means to pay insurance claims. And I shouldn't just be paying you because you billed me. I should be helping figure out if you billed me the right amount, but then compensate you based on the quality of the care you gave the patient, and then give the patient insights about what I just learned about with their care, because I've got to pay the bill, so that maybe the patient can actually be more empowered in managing their own well-being. All that should be part of the system.
I saw an interesting statistic this week. It said more than half chronic disease plagues America, and that makes up more than half of all healthcare costs in the United States. How much difference does it make that nowadays nutrition choices are very different, fitness choices are very different? When you and I were in school, you had recess, you ran around, you had an assigned gym class. When my son was in high school, they studied out of a book how they should work out rather than going and actually working out. So what's the difference today, and how do we kind of retrain society as a whole to be careful what they're eating and to take care of themselves on a daily basis?
Probably the best health advice we got from our parents was to go out and play till it was dark and then come home, right? And it actually was quite effective for all of human history. We have made it hard to be healthy in America. This is the foundation of the MAHA movement. Moms frustratingly trying to get their kids to be healthy, where The kids are told to read the book about health, not to actually do the healthy thing. The foods they buy, 55% are processed, highly processed foods. Of all the calories that are consumed in America, these foods are not designed for human life, they're designed for shelf life. And so many of the products that are in there are also manipulating your taste buds and your desire to eat and your appetite. The usual feedback systems don't work, and that's why we have an obesity epidemic. And to your point, 50% of the country has a chronic illness, and that drives most of the healthcare expenses. The reason we're so much more expensive to take care of than Europe, with twice the per capita cost, is because we're twice as fat. We're 10 times fatter than Japan. So yeah, it's going to cost more because obesity leads to diabetes, hypertension, a slew of a constellation of pathologies, including Alzheimer's, liver dysfunction, kidney failure, all these things that are fearsome complications, but they're all related to the fact that the one thing you can control in your life, you felt, was the fork at the end of your arm, so you used it in wrong ways. So that holistic approach to wellness, where there are things that are more important to how I feel about my role in the world and what I'm going to do with the precious temple of the soul that my parents gave me, my body, is part of this larger narrative. We're not going to fix it just by calorie counts.
And when we say chronic disease, sometimes these buzzwords that are used all the time kind of start glossing over for people. But when we say chronic disease, these are things that if people made good choices in their life, when we say health, that's as basic as eating or walking or doing things they could avoid.
The mistake that many Americans make is believing that the diagnoses they were given are irreversible. And the reason they make that mistake is they're often messaged that. Diabetes is reversible for many Americans. Not all, but if you have type 2 diabetes, you got overweight, you became insulin resistant, then you became diabetic. If you lose weight, it will get better very quickly, and maybe so much so that you don't need to be on medications that you're currently on. So this is not just a minor little tweak. You can actually go back. The hypertension is manageable for many patients with weight loss, exercise, meditation, sleep. The things that we know dramatically impact your overall health affect the barometer of your health, which is your blood pressure. And that also, by the way, has indirect benefits to erectile dysfunction, wrinkles for women. I mean, there's a lot of things. So you can look and feel better by taking care of these chronic illnesses. But let me just broaden the discussion. What is the purpose of a healthcare system? Is it to pay the bills so you get medical care? Well, at the base level, yes. You know, I've got to pay so that the doctors will actually, you know, be compensated so they can open their office and hire their secretaries and bring in nurses. I get all that. But the real purpose of a healthcare system is to get you to flourish, not just survive. What's the benefit of that to a society? Let's do it basically with numbers. So if you were born in 1964, you're 61 years old this year. On average, you're going to retire this year. If I can get you to just work 3 years longer, just that one age cohort, that's worth $1 trillion to the U.S. economy. Just because you're healthy and active and you love your life and you don't want to retire, I want to keep going, I'm going to work another year, 2, 3, $1 trillion to the U.S. economy. That spins off $300 billion in taxes. All of a sudden, all the things we're worried about become, the deficits halved, we have enough money for Medicare and Medicaid and Social Security. All those things become easy to manage if we're a healthier people. If we're sick people with fewer individuals in the workforce, we can't afford the economy that we've gotten accustomed to.
Let me hit on one other area, and that is hospital price transparency. If you're going, say, for an outpatient procedure of some sort, trying to understand what that's going to cost before you actually go is very difficult a lot of times. You can pick up the phone, you can talk to the hospital. On Monday, they may tell you price A for that procedure. 2 weeks later, you may call them and they may tell you a completely different price for that same procedure. It's very confusing, very frustrating for a person who clearly, as if you've got health, you're going to go do it, no matter what the price, but you'd like to plan. Can we do better, and if so, how, as far as making sure someone, anyone, can get an actual quote on what procedure they may have coming up?
Yes, yes, and yes. And it's an obligation now for hospitals to share their prices. There's two realities here. Of course, hospitals don't always want to share their prices, but it's also not as easy as it seems because they price differently for different insurance groups. You basically ask them to share their trade secrets of how they're, billing different groups of individuals. But it's the law. They have to do it. The president has signed executive orders on this. We have legislation supporting it. So we are very actively pursuing this. It's called No Surprises Act. And part of that is to provide some transparency to folks, outpatient and inpatient, about what it's going to cost. And this is a very high priority for us. We're going to go after it. But as part of a larger narrative, what is the role of outsiders doing quality control and what decisions you're making? I would argue that if we truly do the digital transformation that we're discussing, which we've got 60 of the biggest companies in America, who are tech companies, came to the White House a month and a half ago, and in front of the president pledged to do what you're talking about, to get involved in different areas of healthcare, like transparency in hospital pricing. Now we have 200 more who've joined those initial 60. So we pretty much have the whole health ecosystem working with us. But let's think of it as an ecosystem. Let's build the guardrails, build the garden, the walls around the garden, and then allow people to plant the best different herbs, spices, fruit trees, pretty trees, whatever they want to place in there, so that the American people can pick what they want and choose. But the company that tells you what your hospital is going to charge you may not be the hospital. It may be an app that scrapes all the data from every hospital in your area and says, I know you. You're not going to go to these hospitals here, but these you would go to. And amongst the 3 that you might go to, this has the best value for what you're actually needing, which is a knee replacement.
Before I let you go, let me ask you a question a little off the side.
Sports question?
You are, yes, this is the crazy one. You are also a citizen of Turkey.
Yes.
I went to Turkey right after the earthquake, and I watched how they were taking care of their people, their housing, their cleanup, all of that. But the part that amazed me was the healthcare. What they were doing in this tragic situation was absolutely amazing, how well they were handling it. And so it made me think in terms of, we often talk about healthcare in the United States as though it's in its own little bubble. And so when you look around at some place like Turkey or anywhere, I mean, if you look around the whole Middle East region, you look anywhere, how does healthcare compare? Are there some places that do some things better than us? Are there some places that could learn from us? On a world scale, how does all that work?
So my show was in 118 countries. So I travel a lot for many, many years to just do the show, but also to learn about how health is practiced, not just health care, but how do people stay healthy in these countries. And I found a few things to be currently true. Countries that have been left behind in healthcare often were able to leapfrog us because they didn't have legacy systems. It's sort of like cell phones. In countries like Turkey, as an example, when I was a kid, you had to buy your phone number. There weren't enough phone lines. When cell phones became available, it leapfrogged that. Everyone got one and began using them, and using them in ways that in America we weren't using them because we didn't need cell phones, we had landlines. So in countries, for example, like Turkey, has it's called e-nabız. It's an electronic pulse. It is a digital, it's an app, and a national app that has your medical records in it. Your personal numbers are all in that app. So when you go to a hospital, you can show them on your phone the app. Most people have smartphones now. 91% of Medicaid patients, the vulnerable populations, have smartphones. And so countries have made major advances. Saudi Arabia has a building that looks like NASA. It's a control center for the entire country. Every bit of digital data that's being aggregated, and to the point that they know if a knee operation was canceled in Medina or Mecca, on the other side of the country from Riyadh, that was canceled because someone in procurement didn't order the part. And so that shouldn't happen again. So that's the kind of insight that we should be having in America. But at its very core, we will win the battle for health in our kitchen, our living room, and our bedroom. And why do I say that? I would argue the single biggest risk factor we have for health in America is not obesity, although that's pretty important. It's loneliness. When you're by yourself, you don't have a social support system, and you're unable to recover your wellness holistically with the people you care about, you start to become an atomized entity that is no longer sustained by the system. I was in Turkey also after the earthquake. And what I personally take out of this is when everyone puts down everything else they're doing and supports each other, when they're meek, we get better results. Now, what does the word meek mean? When I was a kid, when we were kids, you probably read the Bible, the meek shall inherit the earth. I don't know about you, but I kept saying, why would God want the weak people to inherit the earth? Because I simplistically thought that's what meek meant. Meek means I've got a sword, it's sharp, and I could use it. I could really hurt you. But I'm going to electively sheathe my sword, put it away, because I know we've got bigger fish to fry. We got bigger issues to deal with together. If we all sheathe our swords, if we're all meek together, we can get ahead. When countries face a natural disaster, they do that instinctively. This is a crisis right now in America. Healthcare expenses are increasing 9% a year. That's 3 to 4% faster than the economy. We're becoming a massive, massive healthcare system with a small little country attached. We have got to get our arms around this. And as you pointed out earlier, throwing money at it isn't working now, it won't work in the future. We have to use the funding, we need adequate funding, but we need to use the funding to change what we expect the system to do for us. And the biggest resource that we're not using is you, the American people. We're not empowering individuals to own their health, to own their medical records, which, by the way, you paid for, so they're yours, to safely and securely use that information to educate you about things you ought to be doing every single day. Automate your life in ways that allow it to be default healthy, and then once in a while you can make mistakes. Right now we've done the opposite. Don't pay attention, sloppily go through life, make mistakes, and then when you realize you've got a catastrophe, throw money at the problem.
Right. Final question. The fear. Fear is probably the most effective political tool used in America right now. They scare people about X, they scare people about Y. There are all kinds of worries if people are on Medicare or Medicaid, when they see the government is doing cuts, when DOGE is doing its business. Some who do not agree with the administration have stoked the flames of that fear. If someone is currently utilizing one of those services, do they have reason to be scared? Is their health care in any way at risk?
Medicare has not been touched at all. In fact, we're just putting more money into Medicare because we have to. And there was no legislation to change Medicare. It is what it is. Medicaid, we had to save. And I say that because Medicaid was sort of puttering along until COVID. And during the war of COVID on this virus, massive infusions of resources were put into Medicaid, but not in ways that were sustainable. So we saw Medicaid prices increase 50% in 5 years. 50%. To save Medicaid, what we did was say, okay, let's go back to where Medicaid was in 2020, like the way that it was originally designed to work, and address the issues in Medicaid by taking that baseline. One of the things we had to address, the same way that President Clinton addressed it in the late 90s, was in welfare reform, was a work requirement. This is really important. America should be at work. Our nation has always been one of workers. And so if we have a healthcare system that pays you to stay home, like Medicaid has, you know, as someone who's on Medicaid, who's an able-bodied individual who couldn't work, on average watches 6.1 hours of television or leisure time a day. It's not good for them. They don't want to do that. So like every Democratic president has said, and every Republican president as well, work is the foundation. It's essential for a social safety net program like Medicaid. So we've asked people to go back to work again. It actually will be better for them. It's better for the system because now we can afford to take care of all the vulnerable, the people that Hubert Humphrey actually said we should be taking care of. The kids, the folks who are elderly and without resources, and the people living in the shadows. That's what Medicaid's for. And my pledge is to keep it healthy and sustained for those folks. That's why we're putting $200 billion more into that program. But we're not going to do what was done during COVID.
Dr. Oz, thanks for the time.
God bless.